The case we'll be reviewing today is a 50-year-old gentleman who initially presented to the emergency department approximately 6 weeks ago with a 3mm proximal ureteral stone. He initially elected for conservative management with medical expulsive therapy, and on repeat imaging his stone had moved very slightly distally in his ureter. After discussing options with him, he elected to undergo ureteroscopy with laser lithotripsy. However, on his initial presentation in the OR, we were unable to get the ureteroscope to his stone. He was left with a double J stent and presents today for definitive management with ureteroscopy and laser lithotripsy. For a ureteral stone, I approached the case slightly differently than I would for an intrarenal stone. So in this case, this patient in particular had a stent pre-placed. However, in cases where I don't have a stent pre-placed, I would cannulate the ureteral orifice with an open-ended catheter and pass my wire up to the level of the kidney under fluoroscopic guidance. In this particular case, he had had a stent placed 2 weeks earlier. I grasp the stent and pull it out the urethral meatus and cannulate the stent with guide wire up to the level of the kidney. In patients who have had stents pre-placed, it's important to look at the stent before you pull it out. In cases where there's incrustation or in cases where the ureteral orifice is significantly inflamed, I will actually pass a wire alongside the stent and then remove the stent separately, because there are cases where you can't recannulate the stent. In this particular case, the wire was easily cannulated through the ureteral stent up to the kidney. I drain the bladder and I do not shoot a retrograde straight away, as I'm going to go in with a semi-rigid ureteroscope and visually inspect the ureter and confirm I'm in the right place. I use a 7 French semi-rigid ureteroscope to visually enter the bladder and enter the left ureteral orifice. The ureteroscope is advanced up to the level of the stone.
Although you can use a 365, I still like to use a 200 micron fiber in the ureter for most cases. In this case, he has 2 small intrarenal stones that we'll probably go after, which we may be able just to basket, but this way if we need the laser, we have a flexible laser.
To counter the stone, we pass a 200 micron holmium laser fiber.
Again, here it's critically important to manage your flow. Consideration in these cases is also to use some of the anti-retropulsion devices. However, with settings of 0.2 joules and 50 hertz, we find there's less retropulsion of the stone than with other energy settings. The goal here again is just to paint the distal tip of the stone and work your way back, and you can see the stone really barely moves at these laser settings, and you make such fine dust that it's really nice. And again, it's really important to manage your flow, because there are 2 components that cause the stone to retropulse. There's your flow. You could easily just shoot the stone up, and obviously there's your settings of your laser. So the other thing it's important is really just to take your time. If you get impatient, you really start trying to rush, that's when the stone flies away from you. And you just let the stone come to you. Oftentimes it'll bounce back towards you, and you can see, this is just melting away.
I again use settings of 0.2 joules and 50 hertz. I feel like this in the ureter minimizes retropulsion in addition to dusting the stone. We fragment the stone into tiny pieces that are, and the wire is my guide as to how big I want my fragments.
You can see we cracked it, but the pieces still, they're not flying away. They'll just bounce off the tip of the laser.
In this particular case, I chose a 200 micron fiber because there was consideration we would go into his kidney to treat his lower pulse stones. However, I think it's equally acceptable and in a lot of cases potentially beneficial to use a 365 micron fiber. The benefit is the fiber tends to hold up a little bit better. You have a wider beam, but generally I think they're both generally equally effective in the ureter. In the ureter, I think is where 0.2 joules and 50 hertz has the added advantage, where you see less retropulsion because there's less energy delivered per shot on the stone, and the stone tends to stay in place more as you fragment it.
What we see here is basically as you laser, the stone just sort of flies around in place in the ureter, and you could keep the fiber just in the center of the ureter and let the stone come back to it. You don't always have to go chasing it. I think sometimes when you start going chasing it, it migrates, and it will migrate up some. It's hard to keep it from migrating at all, but you also see it'll come back down to you, and really you could see the fine particles coming off the stone, and the stone, as the stone continues to get, the pieces get smaller and smaller. Honestly, these pieces already are very small. They're the size of the wire, so They're probably already small enough. So these are all very, very small fragments, but since he was pre-stented, I don't want to leave a stent in him. And in these cases, I sweep these fragments out. Even though, truth be told, these will pass on their own, a lot of people wouldn't basket or stent them, and I think you could say you're done right now. These are all about the size of the wire, which is about 1 millimeter, 2 millimeters in size. But again, he came in with a stent, and my preference is to send him out without a stent. I don't want anything in his ureter. So the way I view this is I'm trading the cost of a stent for the basket, and it's better for the patient. Additionally, in this specific case, we're going to go up into his kidney to look for a couple of small intrarenal stones, in which case we almost certainly will need the basket because they're in the way lower pole.
Once the fragments are basketed out, they're deposited in the bladder. The ureteroscope is passed up one last time, and the ureter is visually inspected, and there are no residual fragments noted. At this point, we remove the guide wire and drain the patient's bladder. In these cases, if there's no contraindication, I do give them a shot of Toradol in the operating room, as I think it lowers their risk of having ureteral spasm.